thank you for giving such a great opportunity to introduce my study to all of you. As you've seen, it's a study about epidemiological data in my country, and my specialty is in community and preventive medicine. As you all know, cardiovascular diseases were the first leading cause of death in the world based on reports in 2013. Ischemic and hemorrhagic strokes are very responsible for 3.2 almost million and 3.15 million deaths respectively in the world in 2013. More than 85% of whole deaths and cases are occurred in low and middle income countries, with 44 million disability adjusted life years lost or DALYs. In Iran, based on injury and disease burden study, ischemic and hemorrhagic strokes were the third cause of death, with 1987,000 and 17 almost 1,000 deaths respectively. So with this huge burden of stroke, especially in our country, we decided to gather and all the case fatality stroke about the stroke in our country, and after that we did a meta-analysis on this too. We have 4 major steps for our study. At first, we identify search strategy and databases, and then we searching all the databases, and after that we qualify and assess all the quality of data and data extraction, and after that with using some statistical analysis, we realized if we were permitted to do systematic review on this, and I will explain them all after that. For inclusion criteria, we included all published studies conducted in Iran with necessary data about 20-day case fatality rate of a stroke. All national, provincial, district, and community studies from January 1990 to August 2012 were included without any other limitation. By using the definition of WHO definition of a stroke, which is rapidly developing clinical signs of focal or global disturbance of cerebral function with symptoms lasting 24 hours or longer or leading to death with no apparent cause other than of vascular origin. About selected databases, we use 2 international and domestic databases. For international databases, we've chosen PubMed, Medline, ISI, or Web of Science, and Scopus. And for domestic databases, we use the major internal databases, including Scientific Information or Databases, or SID, Iran Medex, and Iran Doc also. Here you can see our search query. I should explain that we use these mesh terms and this search query by using the GBD 2010 studies, and we also repeat our search query through PubMed. As you can see, we use all mesh words, and we repeat this search query again in other databases and by using EM3 words also. And for internal and domestic databases, we use the combination of them, so because we have to use both of the Farsi words and English words, and also Farsi words separately. Here you can see the figures that shows the diagram of choosing and searching our databases. As you can see, in 3 different steps, we qualify and search the databases. We started from domestic databases. We found at the first level 837 studies, and from international database we found 145 databases. At the first level, we assess them by title, and the next we assess them by the abstract review, and the final we choose them by the review of the whole article. And finally, after quality assessment by using the related checklists like a strobe, which is for observational studies. We included 13 studies just for systematic review, and after that for meta-analysis. Here you can see the characteristic of all study, included study. As you can see, we included 13 studies from different parts of our country. You can see the sample size and mean age of the patients, and also the type of stroke and related case fatality too. And as you can see, we separate them by studying ischemic and hemorrhagic stroke, mixed of them, or the ischemic just stroke and just hemorrhagic stroke. Study population was 15,043. They all conclude mixed male and female genders. 12 studies was in adult population, and one patient includes just children. About study design, I can explain that one study just was cohort, and remaining were just cross-sectional study. One study was population-based, and remaining were hospital-based. About the risk factors, I can say that the most common risk factor among our patients was hypertension, following by diabetes, and the common risk factor for children's stroke was infectious and rheumatic valve disease. To assess if we are permitted to do a statistical test at the next level, I mean that doing system meta-analysis to gather the whole studies, we used 2 different statistical tests. At first step, we should be confident that there is no heterogeneity between the data, between the case fatalities, and if we are permitted to put them together or not. For this option, we use Cochrane's Q test for heterogeneity. It means that it gives you an statistics to be aware if you are able to put them all together. I mean that if you are able and permitted to do the all case fatality of ischemic and hemorrhagic, or there are heterogenes and there you cannot able to do all them together. And to assess about the publication bias evaluation, we also test Egger and Begg statistical test to evaluate the publication bias of the studies. Here we can see the different parts of Iran that we have found, and we were able to find the studies about case fatality of Iran. As you can see, there are a scarcity about the epidemiological data of our country, but that was a good step, and we started with just regions, and now fortunately the stroke registry is undergoing after the finishing our study, and we are hopeful that we could find the data of all country in the future. Here you can see the results of our heterogeneity test. As I mentioned before, Cochrane's Q test for heterogeneity were conducted for 3 domains: stroke subtypes, population mean age, and year of study. And as you can see, only for a stroke subtype it is significant, because our significancy level was 0.05. So it is lower than, and it is significant for a stroke subtype. So we are not permitted to gather the whole case fatality rate for all stroke subtypes, and we have to separate them to 3 categories. So we reported case fatality in 3 different types for ischemic strokes, hemorrhagic strokes, and ischemic and hemorrhagic strokes. About population mean age, there were no significancy, and about the year of study, there is no significancy too. So there were no problem from these domains to do meta-analysis, and we were able to ignore them as meta-analysis. But about the stroke subtypes, we do meta-analysis in 3 different subtypes of a stroke. After doing meta-analysis, we found based and slides that you have seen, 9 studies were included for ischemic and hemorrhagic subtypes, meta-analysis, 3 studies for ischemic, and we have just 1 study for hemorrhagic case fatality stroke which is reported. Here you can see the results of meta-analysis in 3 different parts of our study. For ischemic and hemorrhagic, our 28-day case fatality rate was 23.6% with this confidence interval. For ischemic strokes, which meta-analysis was done for 3 studies, we found 13.3% for them, and with this case confidence interval. And we have just 1 hemorrhagic stroke study, which was reported as 37.6% case fatality. In this slide, the forest plot of conducted meta-analysis for a combination of ischemic and hemorrhagic stroke is seen. And here, as you can see, here is our overall estimate for case fatality combination of stroke and hemorrhagic. And here you can see all 9 studies and this square regarding their sample size. And as their confidence interval is not included in no significant line, so this case fatality is significant for us. Here you can see the results of our publication bias test as Beck's test. You see that it's not significant here. It means that there is no publication bias between our studies that are included in our study. But here you can see the funnel plot of this Beck's test, this for publication bias. Maybe you know that for publication bias, funnel plot of publication bias, if you have no publication bias, all the studies should be symmetrically spread here. But we accepted this because we included just 9 studies. It's lower than 10, so it is acceptable for us, and we just know that it's not significant for publication bias, and we accepted that our funnel plot doesn't show this, and it is natural for our study too. For other publication bias test, which is called Egger's test, it is not significant, so it shows that there is no publication bias between our studies. But here you can see also the funnel plot of Egger's test, and you see that the studies are not symmetrically, they are unsymmetrical. I mean that this is natural. So as I mentioned before, we just included 9 studies to this meta-analysis, so it's natural and we can conclude that there is no publication bias because of that is lower than greater than our level of significance. And here also some studies which can be compared with our study too. In one study in Ukraine, they also do the same study, and they reported the case fatality for both ischemic and hemorrhagic study. So it is also comparable with our study too. The other study in China, they do the same study, and this is case fatality for combination of hemorrhagic and ischemic stroke, so it is almost comparable with our study. The other study in Middle East, they do exactly the same search query and meta-analysis for their study, including Saudi Arabia, Qatar, Libya, Kuwait, Jordan, and UAE, Bahrain, Tunisia, Iraq, and Sudan. But our case fatality rate is higher than which is reported in their countries, and it should be evaluate what is the difference between them. And recent study in Europe that they reported all 25-day case fatality of different types of stroke as a range, and they didn't use meta-analysis for the study. As you can see, in ischemic stroke, our case fatality rate is higher and greater than this, and for hemorrhagic stroke we are in the range of that, and we highly recommend it. We should plan for next studies population-based, I mean not hospital-based, because the most of our studies we included in our study were population-based. I can say it's a major, one of major limitation of our study, and I hope that we can conduct other and more valuable study in the future. Thank you.
Thank you, Yasaman, for this interesting talk. I mean, is there any questions for Yasaman?
You're mentioning that atherosclerosis and stroke is one of the first cause of death worldwide, but in your country, the third one. Can you explain us why?
Yeah. The data that I've mentioned before was based on the last burden and injury study, disease and burden injury study of 2010 in our country. In our country, the first cause of death is cardiovascular diseases, and the second one, as you know, is injury. And the third, they found that is a stroke, including hemorrhagic and hemorrhagic and ischemic stroke. Yeah.
Question, but I only want to say a very interesting presentation, first of all. And what can you say about, is it possible to range the fatality variant of death variant of stroke in Iran, in different part of Iran? You give us the map.
Just a map, yeah.
Yeah. What can you say about a difference in the whole?
Yeah. You mean based on the risk factors, maybe? Yeah. The data about epidemiology of a stroke is very scarce in Iran, and we know it. I've just shown the map to show you that we found the data, published studies only on these parts. Then I know that there are few, but that's the reason I do the study, because I want to show that we have not enough study about this. And about the risk factors, there are a variety of different risk factors regarding the district in Iran. For example, in the north of Iran, we have more hypertension than the south of Iran. And about the risk factors, no, I cannot say definitely that there are we do the study based on risk factors in. Difference, yeah. About Saudi Arabia, I cannot say definitely that they do. Why that's the reason, and it depends on their risk factors. Maybe they included different studies. I don't know about that.
Thank you, Yasaman.
Thank you.